I'm going to have to scream a little bit. I apologize because I'm introducing Dr. Hewett here in a few minutes. Just quick updates specifically for those who are online right now via Zoom. I only ask that you please keep your mics muted. I think they're already muted by default. If there are any questions, and I encourage everyone to ask questions towards the end or at the end of his lecture. For those of you online, we have a moderator here. Just type your question into the chat room, and we'll make sure that your questions get repeated and answered. Good. So I've got the great pleasure and honor, a good friend of mine I've known for years and mentor and learned a lot, everything I know about ACL, knee biomechanics. You know, I talk about this stuff every week in my classes. Largely comes from Tim, his lab, his many students he's had over the years. So, I mean, he happens to be in town for the Academy meeting, Academy of Orthopedic Surgery, and just kind of worked out for him to come here. And you don't realize, like, my first, as a student, as a grad student, going into ASB or APTA, one of those meetings, and you see Dr. Hewett's name on there, and say, okay, I'm gonna go to this lecture, and try to come up, and I'm like starstruck. I'm trying to shake his hand, I'm trying to take pictures. Really, he's that big of a deal. Just to kind of, for those of you who are just taking my my introductory biomechanics, you'll hear, and I'll talk a lot about the work that we do, and we still do it. We're still doing so. Many of you know, ACL, unhappy triad knee injuries is a common, it's very prevalent, especially among female athletes. So, you know, this is an area of research that we are still examining. So I'm very excited to welcome Dr. Tim Hewett for the first time here. Loma.
Well, thank you for having me, Dr. Aguinaldo. It's very nice of you. I'm spending a couple weeks out here in paradise that you all live in. I don't know if you know this, but I'm originally from Cincinnati, but I now hail from Minnesota. And I've lived over the last 6 years through the two worst winters of all time in the state of Minnesota, coldest, snowiest, and this is just absolutely paradise. So I'm enjoying myself. These are two of my students from back in Ohio, Carmen and Katie, and they were in these prospective cohort studies that we've been conducting now for decades. They came into our lab at age 16 as research subjects, became volunteers after they both tore their ACLs at around age 16. Carmen on the left, this is, they're 30 years old now. So this is 14 years later. And as you can see, they both just had cartilage resurfacing procedures. So Carmen, the one on the left, is just graduating with her MD, PhD, ended up with 11 surgeries on her knee. She immediately had a second tear within about 6 months after surgery. And Katie ended up tearing a few years later. The problem with Carmen and Katie is that they're really the rule rather than they are the exception. So there's some big issues here. Yeah, so basically what we use is what we call preventive biomechanics. I'm a biophysicist, biomechanist, physiologist by training. And what we do is look at many different organ systems, and that includes systemic exercise issues like obesity, lack of activity, neurological issues like concussion and joint motor control. Very early on, I still study cardiomyopathies, which is the #1 killer of young athletes, and genetic issues. And I'm going to show you a little of that data today, but where, as Dr. Aguinaldo pointed out, ACL injury, cartilage injuries are sort of the life's blood of our lab for decades now. Now, the approach we use is we focus on specific populations, adolescent athletes, female athletes, minority populations, athletes at relatively high risk. And what we do is we use athlete screening athlete, risk stratification, and then very targeted interventions. And we get the entire healthcare team involved, from graduate students to medical students to physicians, surgeons, physical therapists, athletic trainers, PAs. Everyone is involved in this with the idea that every single research subject is a patient and every patient is a research subject. So what I'm going to present to you today is what I call our 5P, our 5-pronged approach. And what that is it's very personalized, predictive, preventive performance programming. So what we do is we train an athlete with the same techniques that we try to develop great athletes. We try to prevent injuries so that those athletes are out on the field. So again, we use this looking at mechanism I'm going to talk about first, and then I'm going to get into screening, and then risk stratification based off that screening, and then targeted training based off of those risk stratification profiles, and use of preventive intervention. So here's an ACL injury. This is Rebecca Lobo tearing her ACL. At this time, she was the best player in the WNBA. She had won 3 national championships at UConn. And she had her trunk perturbed, and her lateral trunk moved over relative to her foot base. And what that creates is a ground reaction force. So here is her foot hitting, and the ground reaction force, as we all know, is directed to her center of mass of her body around her umbilicus. Now, once that trunk goes laterally, you get a ground reaction force that's lateral to the hip and the knee joint. And what that does is it creates a torque pushing that hip and knee inward. So from a whole body habitus point of view, what you see is this, what we term valgus, which is kind of a messy term, but it just means an internal collapse of the hip and knee. It happens with relatively low flexion. It usually happens with most, if not all, the weight on a single leg or single foot with the foot rotated. Often the foot is somewhat externally rotated, and the center of mass, as I pointed out, is moved away from the foot base. Now, if we just zoom in just on Rebecca's knee here, and I'm going to use hand puppets here. This is my lateral knee. This is my fibula. It's my tibia and femur. So what we get at the knee is this combination with this lateral trunk lean. We get the knee pushed and hip pushed inward. So that's that valgus. But what we term that biomechanically is distal tibia abduction. That confuses a lot of people when we say abduction, because abduction means away from the midline. The distal tibia is moving away from the midline. The proximal tibia is moving toward the midline. In combination, and this all happens very rapidly within 50 milliseconds of ground contact, you get this distal tibial abduction, anterior translation of the tibia, mostly of the lateral compartment of the tibia, which leads to internal rotation. And when that happens all at once, pop, the ACL pops, and now you've got mop ends in your knee. And we're going to talk about why that's so important, why it's a big downstream problem. Now, what we've always used is multiple converging research approaches. And this is actually a paper I wrote with both Carmen and Katie when they were students in my lab. And basically what we said was, we need to use all these different data. So they were in these in vivo studies where we actually tested them in the laboratory prior to them going out and playing high school and collegiate sports. We do full 3D motion biomechanical kinetic kinematic analysis. Then we put that data into cadaveric models to see which one of these loading profiles actually ruptures ligaments in the laboratory. And then off of both of those, we build in silico models, and we have some of the first models of successful models of three-dimensional knee CL, MCL ruptures. And then what we do is we throw all that data together and see where the data hits together from all the different approaches that we use. And that's where we know those are the true and valid data points, when you use several different approaches and come up with the same answer. This is one approach that we use, and we feed this data into our biomechanical models. This is a bone bruise. So very often when you tear your ACL, because there's so much force, the bone actually hits together. Now, again, if we look at this model, what happens if the tibia is coming forward and anteriorly translating and internally rotating, what would you expect to get? You would expect on the lateral femoral condyle anteriorly and the posterior tibial plateau posteriorly, you're going to get them hitting together. And that's exactly what you see here is this posterior tibia and the anterior femur. So the tibia came forward and you can see right where that force projectile went through this. And this is from the front profile. And that's the way you know that that distal tibia is abducted and that the knee is in valgus, because these happen in the lateral compartments. So this, again, this is Carmen, her PhD work, where we showed using cartilage pressure distributions, we found a footprint for actually female ACL injury mechanisms. And when you put this data together from both the computer modeling and from the MRIs, what you see is exactly that pattern that I told you about. Posterior tibia on the lateral side, anterior medial femur on the posterior. So when you look at this together, when you combine tibial abduction with anterior translation and coupled internal rotation, this is the first 3D finite element model we built of this. And what we showed was this: when you put them all together separately, anterior, this is relative strain on the ACL. And what we know is relative strains in the rate of 16+% are what rupture the ACL. Anterior shear increases strain, abduction increases strain, internal rotation increases strain. But when you combine the three together rapidly, that's when you strain the ACL enough to tear the ACL. This is a pivot shift test. And what a surgeon does to, or a PA or a physical therapist, what you're doing is actually forensically reproducing the mode of injury. And what they're doing when they're conducting a pivot shift test is they're applying abduction, internal rotation, anterior translation, and you get a clunk. The knee comes, the knee dislocates just as it did during that injury, which is forensically reproducing the mechanism of that injury. So when we first reported this a couple decades ago, this was actually very controversial because a lot of people thought, and there's still a group that believes, that just a massive quad contraction and a very hyperextended knee are what tear the ACL. So this is relatively controversial. However, if you look at the in vitro data, young cadaveric studies, so all of our studies are done in young cadavers, and what you see is this increased ACL strain with valgus, the same patterns that you see with pure compression or pure valgus. Valgus occurs simultaneously with these other anterior translation and internal translation loads. In silico, computer simulations show the exact same thing. And the valgus occurs very early. So it is what's leading to that ACL. And when you do these in vivo mechanical studies, male versus female, literally hundreds of studies showed that this valgus anterior translation internal rotation mechanism is what tears the ACL. This is Rajon Rondo tearing his ACL. And what he is we're going to call him ligament and ligament and quadriceps dominant, because he's landing on one leg with a very straight leg, and he's letting the ground reaction force control where his hip and knee go, which we call ligament dominance, because he's not using his musculature to absorb and dissipate that force. He's letting the ligament hold that joint together. These are our coupled biomechanical epidemiologic studies that I talked about earlier. So what we do is we bring thousands of athletes, entire teams. This was a series of studies where we took the exact same team. We had labs functioning at the University of Kentucky, Cincinnati Children's Hospital, and Ohio State at that time. And we did validation. So it's very important to know how reproducible and reliable and valid your measurements are. So we took this same team of kids at all three sites and showed that it's highly reproducible, and reliable measures that we take. Here's another, an athlete who's both ligament and quadricep dominant, tearing ACL. Again, these key components, starting out relatively flat foot, and that's what you get, that high ground reaction force when you land on that flat foot. And I challenge any of you to send me videos that don't have these common components, whether it be in football, soccer, you name it, wherever this sport's happening. So what we did with that mechanistic data now is we tried to develop risk profiles. And this is what we came up with when this goes back a couple of decades now. Sorry to date myself, but what we did is we identified parallel neuromuscular imbalances that were directly related to those aspects of the injury mechanism. So this knee abduction, we related to ligament dominance, and I already talked about that. That's use of the ligament to stop your knee from moving rather than using your musculature, especially posterior chain muscular, because those are the agonists, the helpers of the ACL. Low flexion is quadriceps dominance. That's using the quadriceps to primarily activate and stabilize the knee joint. Now, the problem, the quad is an important, big, strong muscle at the front of your knee, and most of us are front-loaded athletes. The problem is that when the knee's relatively low flexion, as that happens during these injuries and when someone's landing or cutting, the knee's relatively straight, and the quadriceps through the quadriceps and then the patellar tendon actually pulls the tibia forward and strains the ACL. The problem is because of the configuration of this joint. So the medial part of the tibial plateau is concave, whereas the lateral part is convex, and both condyles, both the medial and lateral femoral condyles, are convex. So what you have is a convex surface meeting with a concave surface. So that becomes the pivot joint, the medial side. When you have two convex surfaces here, it's easy to cause this movement. So when the quadriceps contracts heavily, this is what you get. And that's a problem, to be quadriceps dominant. Also, this single leg part of the mechanism speaks to leg dominance. Now, most athletes, as we know, are leg dominant, but athletes who have greater risk tend to rely much more on one leg versus the other, especially versus landing and cutting and which one is going to absorb force. And then this increased lateral trunk motion that we showed you with Rebecca, that started with a perturbation. But regardless, athletes where you see a trunk that's out of control, a lot more, especially frontal and sagittal plane motion of the trunk relative to the hip and the plantar surface of the foot, is problematic, and we call that trunk dominant. And what that leads to is this body center of mass moving outside the foot base and caving the joints in. So we did this prospective study that we basically showed that athletes that did not go on to a subsequent ACL injury had about 8 degrees less tibial abduction and about 10 degrees less knee flexion than athletes who went on to a subsequent knee injury. The X's are those athletes that go on to an ACL injury. As you can see, just this knee abduction angle, just this angle in the frontal plane was actually a pretty good, better than 70% predictor of who was going to go on to an ACL injury. But more importantly, if you look at the scatter points here, somewhere between half and 2/3 of these kids are relatively high risk. These are young female high school and college athletes, relatively high risk of an ACL tear. So we go to these neuromuscular imbalances, which we can measure, which leads us and gives us a tool for injury risk stratification. This is my favorite sport, believe it or not. I'm actually a big Reds fan. I grew up, I've seen 3 world championships with the Reds. So we'll see what comes down with the Reds and Padres here. I wish you all well. But this is my truly favorite sport. And what you see here is even in this sport. So what does she do here? She loads, lands flat-footed on that left, and you see that valgus, and she just ruptured her ACL, even on a very soft giving surface. So if I still haven't convinced you of the fact that valgus and internal rotation and anterior translation rupture the ACL, this is team handball. So what athletes do with team handball is they're trying to fake out and juke their opponent, throw around them. What does this position look like? Basically recapitulating that body habitus position of straight leg, trunk perturbation, lateral to the joint, collapse. And what you see is very high risk. The only thing that's higher than women's team handball is Aussie rules football. Because I don't know how many of you are familiar, but in Aussie rules football, what they do is they go up and make these speckies, these spectacular catches. The Aussies shorten everything and then add an E to it. I love Aussie speak, brekkie, specky, whatever. So they go up and make these speckies, and then someone's hitting them, and their trunk goes out. More ACLs happen in Australia than anywhere else in the world by far. And I've spent a lot of time in Australia actually studying with the group at Melbourne, Kate Webster and Julian Feller, just because of that. Men Aussie rules football players are about, maybe 50% more likely to tear their ACLs than women handball players. Now they have, over the last 3 seasons, women AFL, and we predicted this. We actually wrote a paper on this and said this is going to be astronomical, 8 times higher than male AFL players. Now, even in the lower left-hand corner here, what you see is a gymnast. Let me go back. Look at the gymnast in the lower. Is that not playing? Yeah, no. Okay, so this is a person obviously that can exquisitely control her center of mass relative to her foot base. You have to, or you're not a gymnast, right? But what happens when she loses control of that center of mass? Comes lateral, she ruptures her ACL. This is what it looks like in 3D motion in a laboratory. So this is a young athlete who's got a relatively high risk profile. We're asking her to drop off a box, and we've got a basketball set at her max vertical jump height. So she has to be able to collect on the midline of that ball to be able to pull it down. So she has to pull it down. So that's where the focus is. So intentional focus is key. She's not focusing on how she's landing. What you see here is she lands with a lot of force, an asymmetric force. That force pushes her knee in one side versus the other, lands relatively straight. She's out of control, and she's got very high risk. Again, points with that bright dominant leg dominant pattern, flat foot, straight knee, high ground reaction force, asymmetric side to side, pushing her knee and hip just like that into a position, that extended knee position, that quadriceps dominant position, which, by the way, we can alter. We can alter this position. So post-training, this is what it looks like. She actually can jump a little higher. We've set the basketball even higher, but now she's learned to keep her knees and hips out square, activate her posterior chain musculature, especially the glute. The glute is the biggest, strongest muscle in your body. It controls the head of your femur, which basically controls your knee joint in all 3 planes. And again, also hamstring activation, posterior chain is crucial. And we show we can modify that. Critical analysis and feedback are essential. If she's going to rebound that basketball, she's got to be prepared to do that. And if she's doing this as she didn't know before, you have to make her aware as you're training her. This is someone who's just torn his knee ligament. So this is a multi-ligament knee injury, and a very cool biomechanical analysis. Just small perturbations in trunk movement, just small, leads to a knee adduction, that opposite moment, because it takes both active and passive restraints. And this is what happens when you're completely ligament dominant and the ligament's gone. Amazing biomechanical analysis, isn't it? I try not to do that one during a dinner talk. So then what we did is we knew trunk proprioception was important. And we worked with a group of Yale athletes, 277 Yale athletes. And this is Billy Zazilak's work, Jacek Cholowicki, several others. And basically what we did is we put them on what basically is a motorized bar stool. So this thing, they're sitting on this stool, it's hooked up to a step motor, and we moved them 20 degrees, and then just using their trunk with their eyes closed, their arms crossed, they had to reproduce the position where they started and push a button, said, I think I'm back to where I started. So a good measure of trunk proprioception. And what we showed was those that didn't position themselves well, that had a lot of error in that repositioning, were at significantly higher risk of knee, ligament, and ACL injury, especially if they were female. Again, whether you're male, female soccer player, NBA basketball player, you lateralize that trunk if you're trunk dominant, and very often it happens by trunk perturbation. We do not call that, we call that an indirect contact injury. If you have to say, is that a contact or a non-contact injury? I'm going to say it's a non-contact injury because it wasn't a direct blow to the knee. But obviously there's contact at the trunk that leads to that lateralization of the trunk and that medialization of the hip and knee. Again, believe it or not, there are still people that don't buy this, that valgus is actually what tears ACLs. I think it's massive quad contractions and hyperextension. That's just a wrong idea. Again, if you look at, we looked at every video that we could find, and what you see is always this lateral collapse as the trunk goes lateral in the medial hip and knee. We've also looked at this from a growth and development perspective. Our working theory is, as kids grow, because kids prior to puberty, for example, girls aren't at higher risk than boys, and boys and girls are at relatively low risk. What happens with growth is you get these longer levers, the tibia and the femur, and femur and tibia length are predictors of higher risk, as is mass and as is BMI. So what you get is growth. Now in girls, you get less of a spurt because you'll get less testosterone. So you get less relative hip and knee muscle strength and recruitment, decreased relative neuromotor control, increased dynamic valgus, increased knee load, and increased injury risk. And we can use this information, number one, to risk stratify these kids and say who's at high risk, but also develop targeted interventions that directly address those risks and bring those risks down. I should say, we all use the word prevention. Prevention really means you know something is going to happen and you're preventing it from happening. That's not really what we're doing. What we're doing is we're risk stratifying and then risk reducing. And that's kind of important, but we'll never get rid of the word prevention, although it's, I think in science and in medicine, it's important that we work toward using the most accurate and precise language that we can, and risk reduction is more accurate and more precise. So looking at a kid like this, when her tibia and femurs are going to red, she's above the threshold, 25 Newton meters of torque, which puts her in the high risk stratification category. As you can see, both sides, she goes into this category. So what we did, and this is another student of mine, this is Greg Meyer's PhD thesis work. And basically what we did is said, look, most people don't have multi-million-dollar motion laboratories. What if we did this with just 2D video? So we, as you can see up in the upper right-hand corner, that's just straight 2D video, but at the same time, we're measuring 3D biomechanical video, biomechanical analysis, so we can compare 3D biomechanics just to 2D kinematic motion. And what we came up with was this nomogram. As I said, tibia length is a predictor. So this is a young female volleyball player, relatively long limbs. Now, the length of these rulers of the nomogram are directly proportional to their risk incorporation, their risk stratification value. So tibial length is an important valgus, 3 centimeters of valgus motion on one side versus the other. Relatively low knee flexion range of motion is an added predictor. Mass is always a predictor. The bigger you are, the harder you fall. That's physics, that's reality. And if you're relatively quad dominant, high quad to ham ratio on a dynamometer, you don't really need the dynamometer because that's not a really strong predictor, but it does predict to about 20%. So this person using video plus a dynamometer, we said had a 97% chance using 2D video of having a high knee load and being in the high risk stratification group. Well, side by side, we measured 3D biomechanics, and her actual knee load was almost 50 Newton meters. That's double the 25 Newton meter high threshold cutoff. So you can use 2D video. Now, what's the good news in all this? Well, we've done meta-analyses multiple times. We published the first study in 1999 where we showed we could reduce the risk in female athletes, 50% all knee injuries, 2/3 ACL non-contact injuries. We reported that in 1999. Since that time, there's now been 20 randomized controlled trials. Now, the good news is if you address the mechanism, and this is the punchline of the talk here, guys. This is the most important slide I'm going to show you. How do you address this mechanism? Knee abduction, you address with biomechanics and a lot of technique feedback. This problem of low flexion, you power up with plyometrics and recruit the posterior chain, the glutes and the hammies and the calf musculature especially. Single leg part of the mechanism, you do a lot of balance, but very dynamic. Start slow, just static balance, and then move into very dynamic balance situations on one leg, and then return to 2 legs once you have symmetry. And then this foot away from the center of mass, you develop core stability training. And what you do is very dynamic foot-based core stability training that's going to progress. Now, you might start just on core Swiss ball type work, but then you're going to progress out to the feet with plyometrics. If you look at all the studies, the RCTs that have been done, they all show plyometric training coupled with biomechanical analysis and technique were all common components of every study that effectively reduced these injury rates, 50% all knee injuries, ACL, by 2/3. Now, believe it or not, when we first published this back in 1999, people said, nah, you can't predict and prevent an injury. It cannot be done. This is a study that was done by a German group independently, published in Journal of Bone and Joint Surgery. Now, this is called a funnel plot analysis. Now, what does a funnel plot analysis do? First of all, it looks for validity. And second of all, it looks for publication bias, or only positive findings getting published. So what you see here is that line is the 62% or 2/3 relative risk reduction. And what you see is all those studies hug that line. So it's valid. You're seeing the exact same result of 62 to 67% reduction in non-contact ACL injury risk. And none of them fall outside the funnel, which means this is not positive publication bias. Kate Webster from Melbourne, Australia, and I did this series of studies. We did believe it or not, a meta-analysis of meta-analyses, sort of an inception analysis. It's actually on Cochrane Reviews calls it an umbrella analysis when you're combining meta-analyses. So what we did is, this is 20 years, more than 20 years after we've published that first RCT. And what did we show? Relative risk reduction of 50% in all athletes of all knee injuries or all ACL injuries, and 67% or 2/3 in non-contact ACL injuries in girls and women. So we have to develop an algorithm. What's the problem? In a high-risk group, high risk of ACL injury, what is the algorithm that we use? Technique, plyometrics, dynamic balance training, dynamic core, and strength training. So again, what we're doing is using that risk. We're using the mechanism. We're using those neuromotor control patterns that we can identify. We're then risk stratifying, and using all that information, we're developing tools, not only identification tools, but risk reduction tools. Biomechanics, safe and effective technique with a lot of biofeedback, everything from your ear, listening to how loud someone's landing. I used to write grants, and my lab used to be right off of the specialized floor we built for training. And we would bring in a team of young girls, you know, adolescents, and it sounded like cattle doing plyometrics, just boom, boom, boom. And I'd simply come out and say, young ladies, I'm trying to write a grant here and bring in some money, quiet it down. And literally, well, you see a, you know, a 220-pound bald man screaming at you. The sound just immediately like to a quarter of what it was. Well, what are they doing? They're flexing their body more, they're rolling their foot more, and they're absorbing force better. So simple things like listening, noise levels, giving them feedback in a mirror or just a voice feedback or with a camera. Everybody's got a cell phone now. So we use plyometrics, neuromuscular adaptation to stretch and speed, decreasing that amortization phase. So rapid deceleration and reacceleration, which also gives you exquisite and better control of the center of mass and all three planes of motion. Dynamic functional balance and strength, functional speed, and multidirectional power development. We're also making these kids better athletes. We're increasing their, in 6 weeks, 6 to 8 weeks, we can increase their vertical jump by 10, 15%. And core stability training, kinetic chain control, balance, perturbation control. Again, what you're gonna do with these plyometrics when they go out onto a single leg, then you're gonna start perturbing their trunk with balls and partners, and you're going to distract them in many ways so that you're increasing their envelope of neuromotor control under stress. Again, meta-analyses of meta-analyses, non-contact, we show a 62 to 67% reduction. We can make that ACL less vulnerable, knee abduction with biomechanics and technique. Low flexion, plyometric power, powering up, especially the ham, the hip, the glute, single leg, balance, symmetry, and center of mass away from the core, dynamic core stability, dynamic, and again, I can't say that enough, strength that is gonna translate onto the field and onto the court. And I'm gonna argue this. People say, well, this is a fluke. How could you actually prevent something from happening? I'm not preventing something. What I'm doing is risk stratifying and risk reducing. And you can do that because if we can show in the lab that we can increase neuromotor control by decreasing these dominant patterns, and then we can let these athletes go back, and I'll still face surgeons all the time. I'll give, like I did at the academy this week, I'll say, risk stratify, risk reduce. Oh, you can't do that. I don't believe anyone can reduce the risk of any injury because it's too chaotic. However, if I can show you that I can increase neuromotor control and then use that same training and decrease risk by 1/2 to 2/3, then the mechanisms are primarily neuromuscular in nature. I can modify risk and I can modify injuries, and those injuries are modifiable in the mechanisms are modifiable in nature, which is key. That's the good news in this whole story. So again, looking at this combination of abduction, internal translation, AT reduction, anything you can do which can decrease this position and this position is going to reduce your risk of an ACL injury. This is Shay Ralph. This is her 3rd ACL tear. She actually took UConn to 4 national championships as their starting point guard. I presented this to a group of surgeons through the AAOS, and I said, believe it or not, Shay Ralph went on to 5 ACL injuries on that knee, and a surgeon in the back stood up and said, Hewett, you're wrong. And I said, follow me on Twitter and you'll see I'm never wrong. That's not possible. But he said, Hewett, you're wrong. And I was. He said, I just reconstructed her ACL a 6th time. I can imagine that. Let me tell you, you've had one ACL injury, devastating at many, many levels. You have that second ACL injury. At one time in my lab, I had 6 people with 2 ACL reconstructions, because after that second one, that not only gets to your body, it gets to your mind, and you want to figure out how this happened, how to stop it from happening to you again, but to other people as well, because it's just so devastating. So in the next part of this talk, I'm going to talk about how we've gone into risk reduction of second ACL injuries, like happened to Katie and Carmen. So again, this is Derek. Does everyone know the Derek Rose story? Popped his ACL. He was 13 months out his ACL, and he wasn't back to playing for the Bulls, and they were in the playoffs. And the Chicago Tribune not only ripped him, they ripped the coaching staff, they ripped his entire medical staff. The medical staff called me in because they were afraid they were going to get fired. Because again, you've got a $22 million a year athlete who's not playing. He knew it. He said it just didn't feel right. It didn't feel right. And what happened was, when they pushed him back, early following 2 games into the next season, he tore his meniscus. So basically, this is a series of studies, and just very rapidly, ACL, amazing piece of tissue. So we used to do the studies with Ed Gruden, Dave Butler, where we tear the ACL apart like this, just in straight distraction. And what we reported was it took 1,800 newtons of force to tear an ACL apart. So your ACL is this big. It's the first 2 digits of your pinky. It's directly proportional. Your PCL is your first 2 digits of your thumb. That's why one of the reasons it tears less often. Of course, you don't move posteriorly as much as you do anteriorly. Where they cross in the sagittal plane is the center of the hinge of the knee joint, which changes that center as you flex and extend. But this is a very strong, very elastomeric tissue. It takes a lot of force, 1,800 newtons. Now, Pete Torzilli and the group at HSS reproduced our studies and said, nah, it takes 2,200 newtons, which cadavers in New York City are even tougher than everywhere else. But the point is, it takes somewhere between 450 and 500 pounds of force. That's a lot of force. However, as I'm walking across this floor, so I weigh 220, I'm hitting the ground, and the ground's hitting me back. I'm hitting myself with between 440 and 660 pounds of force just walking. So there's enough force there actually to tear my ACL if I'm not contracting my musculature synchronously and symmetrically in a way that's going to absorb those forces. So ACL is amazing. It can resist a lot of force. It's also full of mechanoreceptors. So it senses where the center of rotation is. Not only does it sense 3-dimensional position of the center in the knee joint, it senses the forces and loads on the knee joint. And when we tear those mop ends apart, we lose that. So what you all are doing as rehab professionals when you're working with athletes is, my working theory is, you're developing, so you've blown apart a circuit, you've got an afferent efferent feedback loop, spinal level, very rapid, 80 to 100 milliseconds. And what that does is, so say I were to take my least productive graduate student and decerebrate him. Can't go any higher than the spine. And I were to tug on his ACL, get in the joint and tug on his ACL, what's going to happen? His hamstrings are going to turn on. That's actually been demonstrated in cats, not graduate students. But the point is, you've got very rapid afferent efferent feedback loops. And that sensor is now gone. There's a little data in dogs that there might be, after a year or 2, there might be some neural reintegration into a graft, but that's very sparse data. And even if there is, you're not going to have all 5 types of mechanoreceptors that are in a native ACL, and it's not going to be highly calibrated to sense and respond through the hamstrings in a functional afferent efferent feedback loop. There was a case of a Norwegian who had his ACL reconstructed, like me in Minnesota, always on the edge. He couldn't handle the winter, offed himself at 18 months. They sent his knee to Vermont, where they're experts in looking at these mechanoreceptors in the ACL, and found none after 18 months. So my theory is what's going on with rehab over the next 2 years is you're developing parallel circuits to flow around that blown circuit. Because what happens is afferent, efferent, you're getting an on signal from the blown fuse going through the inhibitory motor neurons in the spine, and that's shutting down your afferent. So there's no signal, and that's why you get that rapid quad atrophy. So what you're doing is over time, you're developing a system, but because you don't have that sensation, you're moving with stiffer knees and stiffer motion, and you're not activating the musculature in the same way. And a third of people at 10 years end up with osteoarthritis. And what we showed was, we reported early on in a relatively small biomechanical cohort that 25% of people at 1 year go on to a second ACL tear, and the third go on at 2 years. Now, people said, well, that can't be quite right. But then the group, Julian Feller and Kate Webster, showed exactly the same numbers. And so did their competitor, Leo Pincheski, the exact same numbers. And again, consilience of data sets, all showing the same thing. Your risk of a second tear, if you're young, active, going back to the same level of sport, is between 20 and 40%, between a quarter and a third at least. So what predicts or what points us to a second ACL tear? Well, internal hip rotation and that valgus moment and motion at the knee. This is so you need your glutes to externally rotate your hip and not allow that adduction at the proximal femur. These are people who go on to a second ACL tear in red, and you can see at that zero line. The zero line is here. And what happens is those at significantly higher risk of a second ACL injury have a net hip internal rotation pulse, whereas those that don't are using their glutes and their hip complex to externally rotate and abduct that hip so it doesn't go into that valgus position. This is Baron Davis rupturing his ACL graft. Now, again, think about that data that I just showed you. Extended knee, flat foot. Now, what's happening in the frontal plane? Watch this hip internal rotation impulse at the hip, valgus at the knee, and he's just torn his graft. This is RG3, second ACL. He's even got a preventive brace on. What's going on here? Internal rotation impulse at the hip, valgus moment at the knee. You said it, well, how could we know we put a brace on him? How's this possible that this could happen? Look at his NFL combine data. What he's doing is a max forward broad jump here. What is he doing? He's actually, I call this an active dynamic valgus person. And I think what they're doing is actually loading up their limb. So they're internally rotating hip and knee to store elastic energy there and then taking off with it. Many great athletes do this, but it puts them at higher risk. That's why many great athletes are at greater risk of an ACL injury. So again, high risk of a second tear, unacceptably high risk. And we're looking for this kid, not this kid who uses his knees like hinges on stiff muscular springs, absorbing those transverse and frontal plane forces, but her who's using her knees like ball and socket joints, allowing the ground reaction force to push her hip and knee inward and rotate and put her at great risk. Basically, what we showed is individuals with that high hip internal rotation moment were 8 times more likely to tear a second ACL, 2D frontal plane valgus motion, 3.5, side-to-side differences in quad dominance, 3.5, and a stiffening knee strategy on a postural stability measure. If we put those 4 together, the receiver operating curve could predict 92% with 92% sensitivity, 88% sensitivity, who is going on to a second ACL tear. This athlete is moving on one limb, swaying her hip, knee, and ankle to the rhythm of that rectangle moving toward and away from her. And we're asking her to stay equidistant to that rectangle as it's moving forward, toward and away. We've got her matched up with athletes, same sex, same body mass, same position player. They'd bring in their best friend who played their same position. This is what uninjured controls look like. She was going at 0.65 hertz. When you go to a slow to a high frequency, you go from in phase between the hip and the ankle to 180 degree out of phase. This is what people with an ACL tear and reconstruction look like. They have more variability in motion at the slow speed. When we go up to the high speed, they lock the degrees of freedom of their joint down because they can't sense it. Here's what someone who's going to go on to a second ACL tear looks like. Exactly opposite pattern. They go from very high variability to locking that joint down. And this is a nonlinear dynamical systems approach modeling that we looked at. And basically what we showed here is that's controls. So when you look at the phasing of the hip and the across the lower extremity, hip and ankle, very linear, very continuous. The middle frame shows someone who's had their ACL reconstruction, that linearity and continuity have begun to break down. Here's someone that goes on to a second ACL tear. They can't sense that joint well, and they go on to tear their ACL. So if you got these varied success, abnormal neuromuscular strategies, stiff knees, frontal plane changes, high incidence of OA, unacceptably high risk of a second tear. And where we're going with this is using neuromuscular training that's very risk stratified, very targeted to see if we can address this hip transverse plane moment, that valgus motion. And we use this combination of trunk, independent and combined, phase progression, degrees of freedom, volume, speed, perturbations, and we have control before progression, because an athlete whose leg, ligament, and quad dominant is going to tear their graft, or even with greater risk, the opposite side. We use lateral jumping, plyometric progressions, start proximally, work distally, and we use this preventive biomechanic approach where we get the entire medical system, including the athlete, their coaches, their parents, so that we can avoid this. Now, this is Carmen and Katie's genetic pedigree. We went to a fun family picnic where we collected blood on all living family members, 34 or 42 family members. This is Carmen and Katie down here. So Carmen and Katie are these identical twins, and they both have 2 ACL tears on the same limb. If we go up one generation to their dad had 2 triplet brothers, all playing basketball, all bilateral ACL tears. So there are genetic components to this, no doubt about it. So we have written a book on this. I don't make anything off of it. You can get it through AOSSM. It goes to ACL Research. I want to thank you for the time you've spent with me, and I want to thank a whole lot of people that contributed to a whole lot of work over a couple decades. Thank you very much. I appreciate your attention.
Awesome. Great simulated talk. Now we're going to open things up to questions, both via Zoom through our moderator, Joshua here, as well as over here in the room.
Any questions?
Question in the back.
Yes, I do think valgus is so both valgus and quad dominance are important. So in a squat, what you want to do is, yes, and there are many ways to, the way I coach this with a kid is I say, sit down on the pot without touching. And that's a good, and of course it gets a chuckle, but it also sticks in their mind. But also, and if they ask, you say your knees are like headlights. You're pointing straight ahead. You want to keep the knees and hips squared out. That's important. But also in the frontal plane, it's important in a squat that you sit back, because that's where you're going to engage the posterior chain. That's where you're going to get the most out of your glutes. You come too far forward and you're going to be training quads, which is, I mean, it's important to train quads, but it's important to keep that balance and to turn on that posterior chain. So yes, both square out the hips and knees and sit back in a squat. Question, Jess?
Yeah, so your study looked at the predisposition towards female studies which
Yes, there are multiple studies out now. Now the data is much more limited. So when we did that meta-analysis, there were some studies in there that had male athletes, and what we showed was you could reduce the risk of all ACL injuries by 50% in males. It's unknown at this point whether straight non-contact injuries, whether you can reduce that in males, although those studies are currently being done. Yeah, males are just harder to work with. They're non-compliant. Believe it or not, it's true.
Yeah, so go back to the first question about flying and then Valgus.
It depends on the individual, but yes, it very often you'll see on the eccentric, people dive in and then they'll square out on the concentric. Well, one of my, it used to, this debate rages actually. There's a lot of people that say that's BS. You can squat any way that feels natural to you. My training partner for years and years and years dove in and then squared out on the way back. I think if you're looking at relative risk stratification, you don't allow that to happen. But again, follow me on Twitter and you'll see some fun battles over this. I think if you're going to program into a person's movement strategy, you better program regardless of whether they're sitting down on the pot or not. You have to stay squared out. If you regularly let your hip and knee cave in movements, it's going to be more likely that it's going to happen on the field or on the court. Yes.
Regarding the development of parallel inherent pathways of proprioception based on supporting certain
There's actually, that's a theory of mine with, I'll tell you, it needs more data. It needs more fill in, and we're working on it. I'm working with a couple, I'm actually one of the reasons I'm here. I'm with a company collaborating with them, trying to come up with tools to do that. Here's the caveat to all this. Developing these pathways takes a long time. So if your knee's never the same, your ACL's not the same, you have to be developing, right? You have to be developing some other parallel networks to sense not only position, but load on that joint. If you have any even very crude measure of kinesthesia, joint position sense or proprioception, that doesn't come down to no longer significantly different from baseline until 2 years plus, on average 2 years post ACL. I actually wrote a paper on that, and I sat on that data for 10 years because I knew people were just going to slam me. Like, what an idiot. No one's going to wait 2 years. I think more important to the point we made in that paper is, so things like strength, especially if you have a hamstring graft, that hamstring strength probably never comes back to where it was before. Bone bruising, graft ligamentization, maturation, quad strength, kinesthesia, proprioception, they all take about 2 years to be not significantly different from control or lateral, even lateral side, which is also, by the way, when you're comparing to your opposite side, because you've got that blown fuse on the involved side and your body wants to move as economically as it can. Well, it can't, because the neuromotor control on your involved side is compromised. So what happens to even out to create economy both sides, you actually decrease control on the opposite limb. So you have significantly increased risk on your opposite limb. And this takes a while. Now, I'm not saying athletes are going to wait 2 years, but I think the important part is to use those tools, and especially the tools that you use to identify risk and the tools that you need to ameliorate or decrease risk need to be the same. So the same thing you're testing with, you're training with, and you're using those to develop those parallel circuits and test and keep testing serially. And because what's more important than the absolute value of those measures, say stiffness in the joint or balance in the joint or kinesthesia, is that it keeps getting better. It's very often when someone hits back to sport and they get away from their PT and training, they actually get worse. And so that window of that first 6 to 12 months, your risk is exponentially higher than later. And there's been good data that shows after in those first 6 to 12 months of returning, your risk of a second tear decreases by somewhere between 10 and 30% per month that you wait longer. So that, but yes, we still need more data, but I say hypothetically, it makes sense that we have to be developing those parallel circuits, and we need to do it with targeted tools and constant focus and feedback on that, constant measurement, and then giving that athlete information of whether they're getting better, staying the same, or getting worse. Other questions? Yes, there is. There's several papers. So for example, if you have an ACL injury, it's known that you have a higher risk of a hamstring injury. So yes, the best predictors of future injury are prior injury. And that doesn't necessarily mean it has to be the same exact injury on the same exact limb. Your lower, for example, if you have this is studies that we and others have published as well. If you have an ACL tear and you go on to a total knee on one limb, your risk of going on to a total hip on the opposite side is up about 50%. So yes, it's obviously it's a kinetic chain that translates symmetrically to both sides, as we alluded to earlier. Yes.
I was just curious about the quad-hand ratio that you talked about, and specifically in your lab in a clinical setting, what are you using specifically to measure the strength of the quad hip?
So what we're using is a dynamometer very fast. So we're at 300 degrees per second flexion, paired flexion extension. The reason we went with that is because we found that to have the most predictive value. Early on, we did it multiple speeds. We did it 60, 120, 180, 300. And I think the reason that is because there's a neural component, especially with the hamstrings, especially with the pull aspect of that. You start to get discrepancies in neuromotor control that you can see easier at those higher speeds.
And then just to follow up on that, has there been a situation where you've had someone look at that test and they were so far quad dominant that you've encouraged them to basically shut down playing time and focus on rehabbing and building up the hamstring?
So when I was at Ohio State, we developed a tool there. As I was saying, our goal at Children's, Ohio State, Mayo, our goal was always, and we came very close to it in many circumstances. One at Ohio State, because we were the team docs for all of OSU sports. So it's one of, if not the biggest athletics department in the country, 1,200 plus athletes. We had overall oversight, so we could actually get very close to making every patient a research subject and every a research subject a patient. And so we had a system that we called at that time P3 ACL. And basically what we would do is we would test these athletes, and their quad dominance would be ridiculously high. The problem is we'd have surgeons who'd say, you know, they'd do a Lockman test, knee looks nice and tight, ready to go. They would go to our therapist and be like at a 40% deficit. And we'd say, they're not ready to go. So what we then developed and offered them was based on that risk stratification data. We would develop, you just don't want to say, no, you can't do it. We would develop a very targeted program. But I can tell you, we had, especially young athletes, we had a lot of kids, but more often the mother or the father crying, going back to the surgeon and saying, you said we were okay, you know? But yes, you have to, sometimes you have to hold them back, but you need it data driven. So that paper that I talked about that Chris Nageli and I published that said, it's kind of tongue in cheek and we say it in a question mark. Should athletes wait 2 years? Because bone bruises tell us that, graft maturation tells us that, hammy and quad strength tell us that, kinesthesia tells us that, you name it. If you look at Scott Dye's work, and the knee is hot until 2 years out, you know? So there's all kinds of data that says it takes quite a while to, you know, 18, 24 months to calm down. So Mike Stewart, my colleague at Mayo, what he would do is take in our paper and say, look, here's what the biology says. I know you guys are going to go to a different surgeon if I tell you have to wait 2 years. So here's where you want to be, 6 months. Let's start negotiating. But let's do it with data. And that paper is not really about wait 2 months or 2 years. It's about keep testing serially and continuously and giving feedback and make sure you're improving, make sure you're meeting your threshold requirements before you go to the next phase of rehab and before you return back to the field. Do it with a very data-driven, science-based, evidence-based approach. Yep, you're welcome.
On that note, with regards to grafts, hamstring versus central patellar tendon, allografts, you know, there's a lot of debate as to which one to use, which is more effective, and not only that, but the donor site morbidity. What's the issue? What, in your opinion, is there one bias towards one specific type of reconstruction, or is it all over the place?
And then again, a Hewett 1 Tim, if you want to see some really controversial major trolling, this would be the area. This would be the area. So this is my opinion based on a fair amount of evidence. You don't go with an allograft in a young kid who's really going to use that limb. Allografts are for people 40 and up who aren't really going to test that limb, are going to horseback, you know, they have subluxation with horseback riding or maybe playing a light game of tennis. So you reconstruct that with an allograft because you don't want patellofemoral issues. So allografts, no, in young athletes. And that data is really clear. Now, again, there's going to be a lot of surgeons who do nothing but put allografts in kids and are going to tell me that I don't know what I'm talking about, but there's a huge amount of data. The Moon Group data that I've been a part of for many years, Moon Group data clearly shows allografts way higher risk of graft failure. Okay, so now you're down to the autografts. Hamstrings. And a lot of people would disagree with me on this. Here's the problem. So I worked with the group in Cincinnati for many, many years, and our surgeons who were the Bengals team docs would never think about putting a hamstring graft in a Bengal or even a real NFL player. You know, it's they would just not do it, right? It's gold standard is a bone, tendon, bone graft because you've got bone, patellar tendon, bone, you've got bone on either end of the graft, and you can, the idea is you get skeletal incorporation. Same surgeon, young female soccer player would use hamstring graft. Why? Well, they would tell you, I'm worried about anterior knee pain, which there's equivocal evidence that maybe you have more knee pain, especially if you're like a carpet layer and you're kneeling on that a lot. And the other reason is cosmesis. You've got a big, ugly worm-like scar across the front of your joint, whereas you don't see the hamstring scar as much. So that would be the bias towards women. But I can tell you, in girls and women, hamstrings grafts stretch out more. They fail more. These are randomized controlled trials. They fail more. And the problem is you're taking someone who is quadriceps dominant tendons already. When females are quadriceps dominants and they use their hamstrings, they tend to fire the hamstring, lateral hamstring first and medial hamstring last. And medial hamstrings are really important because you're not only in controlling anterior translation, you're controlling this internal rotation too through those tendons, and you're taking out 3 of those 5 tendons in the pes anserinus. It's not a good idea. So what I say is I laud the quad at this point. I like the quad tendon. Now, why do I like that? Because you're not robbing Peter's hamstrings to pay Paul. You're not increasing risk of anterior knee pain. You've got massive amount of tendon there that can religamentize. And you're making someone who's quad dominant maybe a little less quad dominant. Now, evidence-wise, there's pretty good evidence that the quad is good, but people haven't been using it long enough. And part of that is just lack of evidence, lack of negative evidence. But to this point, I laud the quad relative to those other, relative to the other autograft options.
I think that surgeons, they do the type of reconstruction based on what they learn. Med school, residency, fellowship.
It's what they do. It's what they do. The really good, really well prepared surgeon knows how to do all of them. A really good, well prepared can equally do a quad graft, a bone tendon bone, a hamstring, an allograft, depending on the needs of that patient. And that point, you know, again, it's hard to generalize because you have to be patient specific. But again, on average, in my mind, an allograft is a big problem in any young athlete. A hammy is a big problem in a young female soccer player who needs to be able to internally rotate her you know, what do you do in soccer? You need to be able to internally rotate your tibia, you know, to control the ball. And so if I'm not going to put it, if your surgeon is going to say, I'd never put one of those in an NFL player, well, they sure as heck shouldn't be putting one in a collegiate soccer player.
Do you have anyone with reconstructed ACL? What do you have?
Yeah.
On the same? Yeah.
Mm-hmm. Yeah. Very often that cadaver is the second choice. Yeah.
What about bracing? A lot of controversy over knee bracing, whether it's used or not. Is it placebo effect?
Well, I'm heading out to the wineries tomorrow with the bracing company. So
should we stop recording?
yes, are there any spies in here? So here's the deal. Remember when I'm talking about this? No, I'm making these massive movements like this, right? That's just instructionally. Let's talk about how big these movements are. So say to tear your ACL, you need about a very tiny amount, say 6 to 8 degrees of this, very small. Anterior translation, about how much? 3 to 6 millimeters of this. Internal rotation, 4 to 6 degrees of that. So think about this. So you've got these bones with this meat and fat around it. And all you have to do is look at that RG3 injury his rookie year in the playoffs. You've got a cylindrical construct around a cylinder that's moving 3 to 6 millimeters and 3 to 6 degrees, that's going to be resisted by a cylinder it's got centimeters of fat and meat between it. It can't be done. That you can't. Now, again, so if there's any way that this works, is this. There was a randomized controlled trial done up in Ontario by a PT group up there, and they showed equal efficacy between a full ACL knee brace and a knee sleeve. Same amount of efficacy. Now, why is that? Because if these braces are doing anything at all, they're working psychologically. Remember, the placebo effect is 30%, right? So, I mean, I don't have anything against if your patient is going to believe, hey, this makes me safer and I feel better, it's likely going to help. That's number one. Number two, development of those parallel circuits. You're developing these circuits through not only the bone, the muscle, the ligaments and tendons, the fascia, the skin. So anything that increases kind of tactile sense to help you sense, position kinesthesia of that limb could be helpful. So I do think if there is an effect, it is through more that tactile sensation and or the psychological aspect to it. It wouldn't be a biomechanical limitation of translation and rotation. That just couldn't work. So the reason the world expert in all this is Kate Webster. I brought up her name many times, from Melbourne, Australia. She developed the ACL RSI, which is a return to sport index. She's a experimental psychologist. She can answer that question a lot better than I can, but I can tell you, we did a series of studies with April McPherson. She went back and forth between my lab and Kate's in Melbourne and did her whole thesis on this. We showed things like fear avoidance, motivation, confidence are critical. Some of the best predictors we've found for second tear are these psychological factors. So yeah, could it be working in that sense? Yes, it could. Though we don't know for a brace specifically, those studies haven't been done. But the psychology of this is absolutely crucial. Also think about psychological parameters almost always work on a U-shaped curve, right? And so if you use the ACL RSI, I highly recommend it. Hey, she's got it now in like 60 languages, and she's got a little app that's 6 questions that you can do on your phone. Serially check it. What we showed was those who were changing to the positive were at much lower risk than those that were changing. So what you're doing is you're going up this curve, you're recovering, you're gaining confidence, you're decreasing fear, you're increasing motivation. And then you can fall off the negative slope on the other side. Why? Going back to sport, you realize, man, I'm not as good as I was before, or man, this thing doesn't feel quite right, like Derrick Rose. Or so what you want is positive deltas, positive changes, and you need to keep tracking that over time. You start getting negative changes then, and this was the focus of Mary Mulcahy's, the speaker I was with at the Academy, is the interventions you can use. She gave a great talk on that, by the way, and she has a paper out on that, just published about a year or so ago, on what interventions, how can you intervene if you start to see this negative psychological slide. It's a big problem. Here's the thing too that people don't realize. So I wrote a paper that said, should we wait 2 years to return an athlete? And I'll tell you, I presented it at AOSSM, which is the big sports surgeons meeting 3 years ago, I think now. And it was out in Colorado Springs, and Freddie Fu and Jimmy Andrews, two of the top ACL surgeons, came up to me and said, Tim, you're absolutely right on. No one's going to do it, but you're absolutely right on. And their point was, because the longer you wait, the lower your risk. But these psychological aspects are absolutely key, and the tracking of it and the giving feedback of it and incorporating that knowledge into your interventions. Because man, when you go back and that knee does not feel right, you'll see it in the NFL. Running backs tear their ACLs a lot, non-contact, and the run, and many of them on a team will have, multiple. They'll say, you're not going to feel right the first year, wait till the second year back. The problem is everyone points to Adrian Peterson. They say, look, Adrian Peterson almost set the NFL rushing record the year he was back, and he came back in 6 months. No, he didn't. He came back at 8 months. But there's always a freak. The freak almost proves the rule, to tell you the truth. Other questions? Yes. I wouldn't have surgery on mine. I can tell you that. Non-surgical intervention is absolutely an option. It is absolutely an option. In America, especially in collegiate and professional and even high school sports, they'll say, yep, you tore your, you'll see it on there, you'll read the news feed. Yep, having surgery, X amount. No, for one thing, you want to delay that surgery. You don't want surgery right away. You want to wait till that knee's calmed down, right? The worst thing you can do, the worst outcomes are those ones where you're up on a ski slope and you pop your ACL and there's docs, waiting with their scalpel at the bottom of the slope. That's a really, really bad idea. And it happens all the time out at all the ski areas. So you need a calm knee. In places like Europe, in Canada, where they have socialized medical systems where you have to wait, in very many of those systems, to save money, especially in places like Sweden, Scandinavian countries, they make them wait, and they make them go through a trial period to see if they can function. Now, the group I was with years ago, we did several studies. Now, people have said, well, a lot of these were chronic ACL tears and that. However, we came up with what we called the rule of thirds. A third of people, when they tear their ACL, just can't function without an ACL. Activities of daily living, and they'll get shifting and giving ways with that. That's a third of people. The middle third of people can go back to activities of daily living and be okay without an ACL. Another third of people can go full level of sport and function very well without an ACL. So I'm in this group, and they don't advertise this, but I'm in the ACL study group, which is probably the 150 top ACL surgeons in the world. I ski with these guys, I run with these guys, I bike with these guys. I can tell you, I know at least 5 of the top ACL surgeons in the world that are ACL deficient that never had surgery. I mean, that tells you something there. It is an option. Theoretically, about a third of people can function at a really high level without an ACL. If you have good rehab, and if you have good, everything that I'm talking about for preventing ACLs, if you don't allow this to happen, if you're using your musculature and contracting and absorbing force in a way that keeps that from happening, and you stay out of these positions, you can potentially function at very high levels without an I would say any athlete should go through a trial of function to see if they can function without, first let that knee calm down, 2 to 4 weeks, just see, you know, swelling, inflammation down, and then see how they can function without it. It should be a real option.
I think a quarterback like John Elway and Philip Rivers play
Yep.
games.
Oh,
ACL deficient.
there's tons of very high level athletes that function. There's at least 20 that you would know the top of your head that are, you know, ACL deficient and function at very high. Now, what a surgeon is going to say is, not all surgeons, but what many surgeons are going to say is, you're going to end up tearing your meniscus because you've got increased rotation in that joint. There's a little bit of data that points to that. There's a lot of data that points that's not necessarily valid. Yes.
What's your take on PRP therapy?
Very interesting. There's a lot of money to be made. It's expensive. A lot of surgeons are offering that. So I was just talking to, there's a guy who's at WVU at West Virginia, and no, maybe he's at Marshall. I get those two mixed up. But one or the other, he's the team doc, and he does what he calls a seated ACL. So he does, I'm pretty sure he uses a quad, and then he seeds it. He seeds it with PRP and something else. Oh yeah, he does like he grinds up a tissue, the leftover tissue that he has from taking the quad, and makes a slurry and like injects that into the, and he's claiming, you know, again, this is a very small cover. Seems like a very nice guy. I met him at the AOSSM meeting down in Nashville in July. He claims he's amazing. He's getting athletes back at 3 months. But again, you've heard these stories. I mean, many times. You know, so like, who was it? The guy at Pittsburgh. I showed him in that video. The guy he's the surgeon that was walking the guy back that dislocated his knee. Jim. I'm blanking on his last name, but he's the one that injected PRP into the hamstrings of the cornerback for the Steelers back in the day. That wasn't all
Safety or
no, not Palomalo. It was say it again. Yeah,
quarterback or cornerback?
cornerback.
Cornerback.
I'm blanking on his name. Very, very well known. Oh no, he was. No, he was. You know, he was a wide receiver. Wide receiver. He was tabbed the dirtiest player in football. Oh, I can't think of his name. Anyway, he cornerback or wide receiver, one or the other. This is years ago, and he injected in, and the guy ended up coming back really quick and played in the Super Bowl and was like MVP. It doesn't bear out to really strenuous, you know, meta-analyses. The only thing I've seen that's been really studied is tennis elbow. You know, there was multiple randomized controlled trials that showed PRP actually was efficacious with tennis elbow. Most other things, hamstrings, ACLs, I mean, they use it on everything. Here's the deal. We know the power of the mind. We talked about the placebo effect. If you pay a surgeon $5,000 or $10,000 extra bucks to inject something into your graft, do you think it's going to work for you? It's just enhanced your potential placebo effect, I think.
And I think there is some kind of just taking a step back and realizing you're dealing with a tissue that has limited blood supply. And if the benefit of increasing blood supply could be
And do you think that can happen with a one-time injection of your own red blood cells?
I'm willing to try it.
If you got the money, baby, I got the time. You know, there's not a lot of evidence, but there's a lot of it being injected, a lot of it being,
Seems like it's happening.
a whole lot of it being injected. Yeah,
Time for one more, and then.
yeah. I think that's what the seated ACL is getting at. I think he's making a slurry. Yeah, that's what he's doing. He's taking the leftover tissue from the graft site and spinning down what he's saying a slurry that his assumption has stem cells in it. So he's saying stem cells, blood cells injected into the graft, and that seated ACL is allowing him to bring players back much more quickly. So.
Most of you are in my biomechanics lab, and for actual course for undergrad and research methods, we're going to discuss some of the things that he pointed out in his lecture, and we may be able to measure some of the biomechanical, kinematic, and kinetic variables in the lab in the next few weeks.
How do I?
No.
Nope.
Was curious. We just wanted like an overall synopsis. If you were to like bullet point
No class
top
on Thursday.
top way for injury prevention for ACL. He was asking, I want to know the most effective preventive injury.
Everybody wants that. Everybody wants that bullet approach. I would say single leg dynamic plyometrics with balance components to it.
Right.
Teaching someone core over foot base.
Yeah. Okay. Cool.
Mhm. Hey, how you doing? Sure.
But you spoke about neuromuscular training, and I was wondering, could you almost call it like neuromuscular re-education that you're doing with that subject? You're telling them, this is where you are, this is where we need you to be.
Yes, you could. Yeah, that's a reasonable term to use, especially post-surgically. Yeah, sure, more than welcome. Mhm. That was a good crew of kids. I mean, they stayed.
Hey, please, you got a Browns fan here. You got a.
OH.
In regards to hamstrings, have you ever done any studies on preventative measures? Because this is going to be on preventative measures, considering like the Nordic exercises. Like
Oh, there's a lot of good evidence, and I call them Russian hamstring curls. That's another debate I like to get into. But yes, Russian hamstring curls have been shown to have good efficacy for reducing hamstring strains. Yeah. And I love them for turning on the posterior chain. We use assisted band ones. So we put a big, like we buy those big where we get them from Akron, actually. Dick Hartzell is the guy's name. I forget something bands. They're big, thick ones, and across the chest, and that way you get the whole eccentric, concentric range of motion.
Yeah, because there's Dr. Aldar actually has been working with the athletes for that. So we talked about it today for
Those are real. There's more evidence on Russian hamstring curls than anything else.
Okay.
Yep.
Awesome. Thank you so much.
You're more than welcome.